Good day and welcome to the last part of our lecture series on sexually transmitted infection. We are going to discuss the management of mixed sexually transmitted infection. So when you receive a patient who has mixed sexually transmitted infection, how do you deal with this patient? This is what we are going to discuss in this last part of our lecture series. I am Dr. Teke Apalata, a specialist in clinical microbiology. So let's start. This is about mixed sexually transmitted infection. So let's see how to manage mixed infections. You have a 20-year-old male patient who presents with genital ulcer disease and mucopurulent urethral discharge. So here you have two syndromes. You have a genital ulcer disease and you have a urethral discharge syndrome or male urethritis syndrome. So how do you handle this patient in terms of management, especially combination of different antimicrobial drugs? So this is the patient, and you can see here that you have a urethral discharge. So you have a urethral discharge, but here you can see that there is an ulceratic lesion. There you have an ulceratic lesion. So you have a patient with an ulcer, genital ulcer, and discharge. Okay. So the first thing is that we are going to, although we are going to discuss the syndromic management, but what you need to know is that it's always a best practice or an ideal practice to collect a specimen. And you will have different types of swabs, whether you are dealing with a discharge in male, you have a urethral swab that you can use. In female, we have cervical swabs, and there are also vaginal swabs if you are dealing with a case of vaginitis. For a case of cervicitis, you have a cervical swab. So if you did not come across our lectures on cervicitis, vaginitis, and male urethritis, just go into our channel. You will find all those lectures there. So, and there are other swabs that we use also in terms of genital ulcer. So usually we use a PropTech swab as a urethral swab and cervical swab because urethritis, male urethritis syndrome, and cervicitis in females, they are almost caused by the similar pathogens. So we use a PropTech swab, and we use a Dacron swab for high vaginal swab to collect high vaginal specimen. And we also use Dacron swab for genital ulcer disease. So those are the type of swab that you can use to collect specimen. You know, we have various types of swab, and the swab comes with a transport media because most of the pathogen causing STIs, you know, they are fragile, they can die if you just send the swab in the lab without putting it in a transport media. So after collecting the specimen here, you put it back into a transport media, then use that. After that, you send to the lab. So we have different types of swab. The selection of the swab is very important, whether you are dealing with a urethritis, cervicitis, vaginitis, or a genital ulcer disease. You need an appropriate selection of the swab. So syndromically, here we are looking at a case of, a case of male urethritis syndrome, okay, male urethritis syndrome, MUS, plus genital ulcer syndrome. So this was the case that we discussed now. So remember that male urethritis, we say that you manage that syndromically by using ceftriaxone 250 milligram single dose IM plus azithromycin oral 1 gram as a single dose. Okay, then as part of genital ulcer, okay, you only need to add a cyclovir to prevent a case, or maybe to deal with a case of HSV infection, because azithromycin will already cover other causes of genital ulcer. Okay, because azithromycin will cover LGV, that is caused by chlamydia. Azithromycin will also cover a case of chancroid caused by Haemophilus ticrae, and azithromycin will also cover a case of donovanosis, you know. So then you only need to add acyclovir, you know, in a case of you suspect that this patient might also have herpes, or because herpes is prevalent mainly in our setting. But azithromycin, if you suspect that the patient might have a syphilis, you can repeat also a dose of azithromycin a week later. You can repeat a dose of azithromycin. Otherwise, if you have to give ceftriaxone injection, you give penicillin injection, then you have azithromycin and acyclovir, it will be too much. So you start with this patient on ceftriaxone, azithromycin, and acyclovir. Then you invite the patient, after a week, you repeat a dose of azithromycin, okay? So, but in female, you can see here, if it was a female patient with a vaginal discharge syndrome plus genital ulcer syndrome, you see that you still have your ceftriaxone, you have azithromycin, you add acyclovir, but in female genital discharge, remember that we also add metronidazole. So you will have your combination of ceftriaxone, metronidazole, azithromycin, and you also add acyclovir for HSV infection. Okay, so those are the commonest combination that you see male urethritis. But if you have a patient with a male urethritis and balanitis, balanitis is a fungal genital infection in male. So you can use your ceftriaxone and azithromycin plus clotrimazole cream, okay, for a fungal infection that is against balanitis. Okay, so male urethritis syndrome plus balanitis, you know, you use ceftriaxone, azithromycin plus clotrimazole. Male urethritis plus genital ulcer disease, ceftriaxone, azithromycin, and acyclovir. If you suspect syphilis, invite the patient to get a second dose a week later. Vaginal discharge syndrome and genital ulcer disease we have. So this is how you do a combination, how you deal with sexually transmitted infection, mixed infection when you are dealing with a patient with mixed infection. So the most important thing is to take a good history, do a very good physical examination of this patient, and have an idea of whether the genital ulcer syndrome, what is the likely pathogen, you know, whether you have inguinal lymphadenopathy or BIBO or not, it can give you an idea, or whether the genital lesions are herpetic lesion or not, it can give you an idea whether you need to add acyclovir or not. But the male urethritis, you have azithromycin and ceftriaxone, or female genital discharge, you have azithromycin, ceftriaxone, and metronidazole. Then you add acyclovir if you are suspecting any herpetic lesions. Thank you very much and goodbye.